Hi everyone, this is Tim, your lecture instructor for the Paramedic to RN Transition Program. This voiceover is going to be on Chapter 20, which is Eating Disorders. If you haven't noticed I didn't do a voiceover for post-traumatic stress disorder. The reason why I didn't is because it was pretty dry. I did record one, but it was to the point where I really was just reading the slides and not really offering anything that was not of importance or not that was actually found in the book. So that's why you didn't find one there. But this one I actually think is a little more important because as a nurse at the hospital, I tend to actually take care of patients that have eating disorders, whether it's not enough. We're going to take care of them because of the problems that they will have physically, whether their labs being off, whether or not they need tube feedings, whether or not they have GI issues. There's a lot of things that a medical surgical nurse will see and actually take care of in patients with eating disorders. So I thought this was a little more important and something that's a little more relatable. So eating disorders, if you continuum, we have got anorexia, which is eat too little. We got bulimia, which is eat too chaotically, and we have obesity, which is eat too much. The categories are anorexia nervosa, which is on page 393 in your book, chapter 20. Um, we've got binge eating and purging, and we've also got bulimia nervosa. With anorexia, with the binge eating, I think that what happens is that anorexia is all about eating and or not or the lack of eating. But at some point, your body will tell you psychologically that you're starving to death and that you need to eat, and eventually you will eat, but you eat with the intent of if I eat it all because I'm starving to death, it's not really good because now you're shocking your system. You went from being not getting it and your body starving itself, and it will literally store what it does get, to all of a sudden you binge eat and you're stuffing it full of food and nutrients that it's not used to, and it doesn't do very well. Then we got the bulimia, which again, it's more of the eating too chaotically. Instead of eating breakfast, lunch, and dinner at being 8, noon, and at 4 or 5 in the afternoon, you're really kind of either eating breakfast, but you're not eating the rest of the day, or you're skipping all of your meals except for dinner. I mean, it's just being too chaotic. There's nothing that your body will do on a regular basis. And again, your body thinks that it's constantly starving, so it will literally take whatever it can get when it gets it. Other related disorders, there's binge eating disorder, and there's also night eating syndrome. So etiology, there's biological factors. There's a genetic vulnerability. There's disruptions in the nuclei of the hypothalamus relating to hunger and satiety, which is the satisfaction of appetite. And then there's also neurochemical changes, norepinephrine and serotonin. Not known if these changes causes disorders or a result of eating disorders. So again, there's something either genetically or neurologically, as far as chemically, wrong with your brain that doesn't tell you that I need to be eating at certain times, um, especially telling your body that you're actually hungry. I do not have an eating disorder, but I will tell you that I am between myself and my family, we grew up eating breakfast, lunch, and dinner just as everybody else did. But the older I got, my sister, myself, and my father, we have learned to eat when we're actually hungry as opposed to eating because it is breakfast, lunch, and dinner. So if it makes any sense, I will eat, the breakfast in the morning. And it's not because I'm hungry. It's just that I know it's breakfast and it's time to eat. I could skip breakfast. I could skip lunch. I could probably skip dinner. And then when it comes to evening time and it's time for bed, I feel a little bit hungry, but I'm going to be going to bed, so it's not a big deal. I mean, I do not have the I don't go days without eating because I forgot. It's just more of, I think there are certain people who actually eat because they're constantly hungry. I also think that there's people who eat only when they're hungry. And I also think that there's people who are, on some sort of actual schedule of breakfast, lunch, and dinner, which is the way it really should be. The more smaller um, meals that you consume, the more your body does not believe that it's starving and it doesn't hold on to all the empty calories and stuff. Whereas with myself or other people who have, problems as far as eating when we are hungry, your body just kind of holds on to that stuff. And then, like I said, it doesn't know when the next meal is coming. So it stores it the way it should. Developmental factors, their struggle with the autonomy or identity, overprotective or enmeshed families, body image disturbance and dissatisfaction. There's also separation, individualization and difficulties, family influences, family dysfunction or childhood adversity. And there's also social cultural factors such as media pressure from others. See 20.1. Let's see, physical problems of anorexia nervosa. Let's see here. Let's see, there's the box. On page 394, risk factors for eating disorders. Got the, it's pretty okay. It's probably a good to know, not necessarily needed to know. All right, so cultural considerations. Increased prevalence in industrialized countries, most common in the United States, Canada, Europe, Australia, Japan, New Zealand, and South Africa. It's less frequent among African Americans in the United States and equal among Hispanic and Caucasian women. So I think that, if we go back to one where it talks about the body image disturbance and dissatisfaction, I think we all kind of agree that, we between TV and Facebook and social media and everything else we're constantly looking at 24/7, we're reminded that we don't look perfect. And I think that after a while you keep getting reminded that you're not perfect. You either have to learn to accept the fact that that's the way it is, or you try to do something about it, and based on who you are or how you are or what factors that are influencing your life, that's when the eating disorders start to come into play. So I think that was the whole point about this slide and this slide. It was just more of we're constantly being reminded of our impurities or imperfections, and we try to do what we can to actually do that. So cultural considerations, I think, again, it's more in countries that are not starving, because I'm sure if you went to a third world country where they were starving, they probably would look at us and realize how healthy and well maintained that we really are. So question, is the following statement true or false? One current biological theory about eating disorders is that it involves a disruption in the cerebellum portion of the brain. This is false. One of the biological theories of eating disorders involves disruption of the nuclei in the hypothalamus that relate to hunger and satiety. So, the anorexic nervosa is refusal or inability to maintain minimal normal body weight. It's an intense fear of gaining weight or becoming fat, significantly disturbed perception of body shape or size, and a steadfast inability or refusal to acknowledge seriousness of the problem, even that one exists. So this is for people who, believe that they are fat and they're trying to lose weight. So basically, they're really just starving themselves. They just do not consume food, or they get to the point where they're, eating less and less to the point where it's dangerous, not only physically, but it's also psychological. The onset is usually between the ages of 14 and 18. Denial early on. There's depression and lability with progression, isolation, and medical complications. 20.2. There's page 397. There's medical complications of eating disorders. We've got weight loss, so between musculoskeletal, metabolic, cardiac, GI, reproductive. Those are probably definitely things that I would look at and be very, very familiar with. So other things, medical management, weight restoration, nutritional rehabilitation, rehydration, correction of electrolyte imbalances. We got psychopharmacology, which is amitriptyline, kyprophethidine, olanzapine, and fluoxetine. Psychotherapy, which is family therapy, individual therapy, and cognitive behavioral therapy. This is probably very important because the individual cannot just do it themselves. So not only do they need therapy for themselves to start different behaviors and patterns and different way of thinking, but they also need family to help them and to be support and be able to try to change the way they feel and how they actually think. Bulimia nervosa is the recurrent episodes of binge eating. It's being secretive. It's compulsory behaviors that avoid weight gain, which is purging, the use of laxatives, diuretics, enemas, emetics, and fast excessive exercise. So this is for people who actually will stuff themselves to the point where they can no longer consume any more food, but then they use something to be able to get rid of it. So they get the ability to eat, but they're not really keeping it. Recognition of behavior as pathologic, feelings of guilt, shame, remorse, and contempt, and usually normal body weight because they do get some sort of nutrients. The onset is usually late adolescence, early adulthood, average age of 18 to 19 years, often begins during or after diet episodes. Possible restrictive eating between binges, secretive storage and hiding of food. And the treatment is usually cognitive behavioral therapy and then psychopharmacological, such as antidepressants. The typical age of onset for anorexia is which of the following? 10 to 14, 14 to 18, 18 to 22, or 22 years or older. The answer is going to be 14 to 18. Most commonly, anorexia begins between the ages of 14 and 18 years old, which is where they're children are very vulnerable to really wanting to look a certain way and trying to fit in. So, eating disorders and nursing process. So what you're going to assess is history. Model child, no trouble, dependable, eager to please and conform and avoid conflict. The general appearance, such as mood, is slow, lethargic, emaciation, which is anorexia, or not unusual, which is bulimia. So basically, you're looking at them. Do they look like they're starving to death? Do they look like as if they're, trying to be easier to please and actually try to fit in? And then how is their mood? Is it flat? Is it jolly? I mean, these are definitely cues to be able to tell you if there's actually something wrong with them as far as eating habits. Let's see here. Also other assessments, thought process, content, preoccupation with food or dieting, sensorium, intellectual processes, judgment and insight, self-concept such as low self-esteem, and then roles and relationships. How do they fit in? Physiological self-care considerations can be found on table 20.2. Well, let's see here. I did find on page 399 the University Diagnosis of Ineffective Coping for Anorexia. I think that's actually pretty good to actually look at as far as signs and symptoms of things you're going to assess and things that you're actually going to do for interventions. Although I didn't find the self-care considerations. Let's see here. Nope. All right, so let's see here. What other things we have? Eating disorders and nursing process. As far as application, there's data analysis, nursing diagnoses. Again, your book actually has a couple in there. I think that those are really worth being very familiar with. Outcome identification. So establish adequate nutritional eating patterns. Eliminate compensatory behaviors, such as excessive exercise, lactose, diuretics, and purging. Demonstrate positive coping mechanisms, verbalize acceptance of body image with ideal body weight. So again, between bulimia and the anorexia, you're really trying to get your patient to realize that, it's hard for you to be able to get them to see themselves the way that the rest of the world sees them, but you got to try your best to be able to get them to try to change that thought process. And again, the more they actually gain the weight and look more healthy, they still think that they're ugly and fat and hideous and things like that. So it probably takes a while, but changing certain behaviors at least gets them on some sort of road and path. Let's see here. Other things, data analysis, outcome identification, interventions such as establishing nutritional eating patterns, identifying emotions, developing coping strategies, dealing with body image issues, and providing patient family education. And then again, you're going to evaluate it. One thing I actually was finding too in this book, on 408, there's actually nursing interventions for eating disorders. So establishing nutritional eating patterns, sit with the client during meals and snacks, offer liquid protein supplements if client is unable to complete meal, adhere to treatment program guidelines regarding restrictions, observe the client following meals and snacks for 1 to 2 hours, weigh the client daily in a uniform clothing, be alert to attempts to hide or discard food or to inflate weight. Helping the client identify emotions and develop non-food related coping strategies. Ask the patient to identify feelings, self-monitoring using journals, relaxation techniques. So I think these are really good as far as interventions. Not, you just don't try to feed them and walk away because they're not going to be trusted in that way. But I also think that certain things you could do, eating with them or feeding, make sure they eat and doing something with them while they're, doing these things to preoccupy their time. On 409, they have client family education. Again, this is probably good for the support of the patient themselves. So let's see here, community-based care. So hospital admission only for medical necessity. So again, this is where I take care of these patients. They come to us because of the fact that they're malnutritious, their electrolytes are off, they're dehydrated, they're having GI issues, they're having all the issues that they've mentioned previous to this. Which is on 393. It's the physical problems of anorexia nervosa. So again, when you're looking at menorrhea, constipation, hair loss, dry skin, dental caries, pedal-edema, bradycardia. I mean, those are things that these people are brought into the hospital for, and those are things that I'm taking care of. Once they get medically cleared, then it turns into a community setting, which is the partial hospitalization or the day treatment programs, individual or group outpatient therapy, self-help groups. You're trying to get them as much help as they possibly can. Mental health promotion, education of parents, children, young people about strategies to prevent eating disorders, early identification, appropriate referrals, routine screening of young women for eating disorders. So question, is the following statement true or false? Self-monitoring is an effective technique that a patient with anorexia can use. False. Self-monitoring is an effective technique that a patient with bulimia can use. So again, you're not going to tell somebody who is anorexic that does not want to eat, you're not going to be able to give them and believe that they're actually able to self-monitor themselves and be effective. Let's see here, self-awareness issues, the feelings of frustration when the patient rejects help, being seen as the enemy if you must ensure that the patient eats, and then dealing with own issues about body image and dieting. It's, I can't go into, up to somebody who is extremely heavy and tell them how to do different things and try to begin to understand where they're coming from when I'm not heavy myself. So again, you can't necessarily match them up right with the therapist, but in the same sense too, you don't make them believe that you think that you're able to actually able to identify with them unless you've actually been through this. But don't get frustrated. Do what you can to be able to, and do what you know that you need to do to be able to get them to eat and to get healthy, and try to give them the resources to be able to deal with the issues that they're having as far as their body images. That's all you really can do. All right, so that was a fast 18 minutes. Again, I would probably concentrate on the boxes that I've pointed out. I think those are good things to know. And then, like I said, just keep it pretty plain and simple. If you have any questions, let me know.